All right, welcome back to our participants. My name is Justin Mauger. I'm the community health educator for Central and Eastern Washington for the Washington Poison Center. It's nice to host you all here today. Just a couple quick housekeeping reminders before we jump into this. This is the final day of our series. We will soon have the presentations and links to videos available on our website, so keep an eye out for those. Big thank you to our sponsors and partners. We work for Health Washington, the Washington State Department of Health Drug User Health Program and Teen Health Hub, as well as Washington State Healthcare Authority and the Friends for Life program. This is our first year at opening our series to sponsors, so we thank you very much to our early adopters. Additionally, as participants who are tuning in, you are muted, so please direct questions and comments to our chat box or the Q&A on Whova. Finally, if you want a certificate of attendance, you will need to take the survey that will be emailed to you from Whova at the end of the series. Alas, it is my privilege to introduce our presenters today. Dr. Holly Davies is a senior toxicologist at the Washington State Department of Health. Her work focuses on evaluating uses and exposures of toxic chemicals and identifying actions needed to protect human health with an emphasis on prevention, safer alternatives, and new approach methods. Mallory Little is a toxicologist at the Washington State Department of Health. Her work focuses on protecting the public from contaminants in water, reducing exposures to methamphetamine and fentanyl, and tracking the human health impacts of contaminants of emerging concern in tires. So I thank you both very much for being here, and I pass it over to you.
Thank you. We really appreciate being invited to be part of this series. As we're presenting, we encourage you to ask questions. As Alex just said, you can put that either in the chat or the Q&A box. Especially want you to ask questions if we say something that you disagree with or if is different from something you've heard somewhere else, because our work gets better when we hear from different people. To help address the issue of drug contamination and drug residue that's left over from people using the drugs, we created guidance last year. I'll begin by describing the background that led to the creation of our guidance. In 2023, workers at a supportive housing facility in Washington reported strange smells, headaches, and air quality issues. The facility hired decontamination contractors to test the facilities for drug contamination, and residents and workers ended up being evacuated. And meth contamination was detected at very high levels in many units, as well as the common spaces. In this facility, the max concentration of meth was 4,000 micrograms per 100 square centimeters. And for reference, our health effects-based decontamination standard is 1.5. They also found fentanyl at 3.1. And while we don't have a state standard for fentanyl, there's an occupational exposure limit of 1 microgram per 100 square centimeters. Meanwhile, other supportive housing facilities in the state also had residents that reported health effects like skin rash, memory loss, seizures after turning on the heat. And so they also tested and detected high concentrations of meth and fentanyl. One of these facilities had a really high fentanyl, which I put this result here just so you can see how high it can get, and that was at 300. The decontamination process using DOH certified contractors is expensive, especially for large buildings such as these supportive housing facilities. And the process of decontamination also resulted in unhousing residents in the wintertime. So as a result, local health requested a Department of Health work group to develop guidance that balances the needs of the residents, the facility operators, and the workers, as well as balancing exposures to the drug residue and the need to be housed and access other services. Multiple partners contributed to this guidance, and everyone brought different goals and perspectives. There's a lot of people at health that are working on drug use and housing. The toxicology section that we're a part of is a small part of the state's efforts in this space. And we've been focused on reducing environmental exposures to the general public. So that includes anyone who may come in contact with drug residue, such as residents and staff of these facilities. The work group I mentioned was comprised mostly of local health officers and other representatives from local health departments, as well as other partners listed here. Local health in particular plays an important role in addressing drug residue and contamination. Local health departments answer questions from multiple people, and the local health officers decide if a property is contaminated and requires decontamination under our state law. DOH also has a clandestine drug lab program that addresses drug manufacturing, distribution, and storage. Our guidance is for situations where decontamination by a DOH certified CDL contractor is not required. And I'll explain more about this on the next slide. We also have a community health strategies for homelessness program that contributed, as well as our DOH opioid response program. Externally, the Washington Poison Center, the Department of Labor and Industries, the Department of Commerce, and housing operators all contributed significantly. This is a simplified legal context using different colors to demonstrate the legal landscape and specifically what's covered under our state decontamination law in the blue boxes and what's covered in our guidance in the yellow boxes on the right. The left side is a simplified version of our contaminated properties law and rule. A drug lab involves law enforcement, local health department, and decontamination by a certified CDL contractor. The contractors are trained in testing, personal protective equipment, effective decontamination, and disposal of the contaminated waste. Within the rule and law, there are no quantified definitions for drug manufacturing, distribution, and storage. So that is something that's worked out with law enforcement and local health. The local health officer is the one who has the authority to determine if a property is considered contaminated and needs decontamination by the contractor. Last year, Department of Health issued an interpretive statement to clarify what happens when there's methamphetamine use in a transient accommodation. The interpretive statement is not a change in the statute or regulation. It just clarifies that the authority to determine if the property needs decontamination in that instance also resides with the local health officer. So that would be the kind of decision point, contamination, whether the decontamination is needed or not needed. And then obviously there's a longer process underneath the CDL contractor and decontamination. The right side of the flow chart in yellow contains the processes for all other property types with drug use. So again, not the manufacturing, distribution, or storage, and shows where our guidance comes in. The scenario is not covered in our current law. In these situations, the property owner can choose to test themselves or get the property tested by a contractor. They can contact law enforcement and local health for guidance and assistance, and they can clean the property themselves using our guidance, or they can hire a contractor. In the next few slides, we'll go over the guidance more. The guidance is intended to work with the existing processes and procedures of a shelter or supportive housing facility. We wrote the guidance to be both comprehensive and flexible because there are many different types of housing with different amounts of resources. We also have a shorter 2-page summary document available, and both of these are linked on our drug residue webpage, which we'll talk about more at the end of the presentation. Again, the guidance is for when someone's not required to decontaminate with a certified contractor. The beginning of the guidance also includes our definition of residue, which is any form of methamphetamine or fentanyl left over from use, whether it's visible or not. And this includes pills, powder, vapor or smoke buildup, liquid, dermal patches, and drug paraphernalia. And we've defined residue to differentiate it from contamination, because contamination is a legal term in our state law that requires decontamination. So this would be for amounts of drugs that have not been determined to be contaminated by the local health officer. We also include overdose resources here because it's important to provide medical care if there's someone who needs medical care. Overall, our guidance is not intended for these situations. We are picturing a space, a room that is empty of people when you're starting to look at this cleaning guidance. And at this point, I'm going to hand the presentation over to Mallory to tell more about the details in the guidance.
Thank you. So our guidance also has a section on health effects from drug residue. So we're most concerned about accidental ingestion of drugs because this has caused children to overdose. Children have more hand-to-mouth and exploratory behavior, and they are also smaller than adults, so they are more sensitive and vulnerable to drug residue. And overdose from drug residue has only been seen in young children and not in adults. As for dermal contact, while these drugs aren't well absorbed through the skin, there have unfortunately been instances where fentanyl patches have accidentally become stuck to children and caused them to overdose. This is very rare, though, luckily. For breathing, there is limited research about what health effects result from inhaling leftover residue, but what has been published says that it is possible to experience health effects such as headaches, coughing, or difficulty sleeping, for example. These effects are expected to go away once you leave the exposure area. And after someone has smoked, people may breathe in leftover smoke or particles in the air. It's not known if smoking fentanyl leads to levels in the air that are unsafe for workers. Without this additional data, we assume that fentanyl smoke is as harmful as other types of smoke, like tobacco. And so we provide the DOH general smoke guidance where we recommend people, especially pregnant people and children, avoid exposure to all forms of smoke. We have a separate guidance document that has more information if you're curious, called Health Effects from Exposure to Meth and Fentanyl Residue. And that is also linked within our exposure practices guidance as well as on our drug residue webpage. So in our guidance and on the right side of this slide, we have listed surface contamination limits. There is a Washington State decontamination standard for meth, which is 1.5 micrograms per 100 centimeters squared, as Holly mentioned earlier. There is no state standard for fentanyl, but for informational purposes, we included the surface limit for fentanyl derived by the American Conference of Governmental Industrial Hygienists, also called ACGIH, as a potential reference point as well. Since this is not a state standard, it is not regulatory. However, the methamphetamine standard is regulatory and is used in situations covered by the contaminated properties law that was just described by Holly on the earlier slide. So imagine the left side, the blue parts of the slide that Holly was describing. This value was originally calculated by the state of California and is human health based, and Washington reviewed their calculations and adopted this value in 2014. Our first Washington State decontamination standard for methamphetamine was 0.1 micrograms per 100 centimeters squared, so it was lower than it is now and was based primarily on the method detection limit. The current meth standard was derived from the lowest observed effect in a sensitive population, which was identified as appetite suppression in pregnant women. The state of California reviewed the literature on other health effects resulting from meth use, including those listed here in the bullets and more. The sensitive population used to derive the methamphetamine standard is children 6 to 24 months of age because of age-specific behaviors and their frequent contact with the floor. California did not include the inhalation route at the time due to limited information in the literature. But if we reassess the standard now, we would include this route in our assessment, and so this would potentially result in a lower standard. Other counties, cities, states, and federal governments have similar standards to Washington State for methamphetamine. The highest level we've seen is 4. So the state of Colorado has a general standard of 0.5 micrograms per 100 centimeters squared, but also has a standard of 4 for attics and crawl spaces because these areas are less accessible to people. And Minnesota also has a slightly different approach in that they have a standard of 1.5 micrograms per 100 centimeters squared for methamphetamine use and 0.1 micrograms for former methamphetamine labs. During the formation of this guidance, we contacted multiple health departments to see if they're considering recalculating their standards, and none of them were. So this slide shows a decision table we created to help decide whether a certified contractor should be hired. As Holly mentioned earlier on the legal context slide, local health officers determine if decontamination is required, so that blue left side of the slide, or not required, which was on the yellow. And Department of Health can't decide this for local health officers or property owners, but we can help with what to consider. So what does go into this decision process for when a DOH certified contractor should be hired? This decision table includes factors So we can't weight these factors for local health officers or property owners, but we can help with what to consider. For housing facilities, there are a lot of different scenarios and different housing types, from single night stays to much longer stays. There's a lot of gray area here, and so the local health officer decision will be dependent on the context of the situation. Also, cost and time. A facility may not have the finances necessary to afford decontamination, nor the time required. This process can take months, displacing people who lived in the area. This brings in the second row. Some facilities or properties may have alternative options for people to live in and or use, which would make the time needed in blocking off of the affected area by a contractor less impactful. But this may not be an option for this facility. So this factor may be a moot point if the drug residue is extensive and affects multiple rooms, which does sometimes occur if, for example, an HVAC system, so the heating, ventilation, and cooling system spreads the residue around. The levels of residue are obviously also a factor. If levels are below the state decontamination standard and the non-regulatory fentanyl standard, then a contractor and cleaning obviously would not be necessary. But if the residue is higher than these values, and especially if they are several times higher, then we would advise considering hiring a contractor. And as for the residue itself, a few spare intact pills can be easily cleaned and are less likely to spread residue. But if an area is more visibly affected, or if heavy use is known to have occurred, higher levels of residue are likely. I will discuss visibility on the next couple of slides, but it's important to note that high levels of residue can be present that are not visible. If health complaints are present, consider testing. You can consult our separate health effects document that I referred to earlier for information on clinical and non-clinical effects of these drugs to compare to health complaints. Exposure is also important to consider. If the area is not frequently used, it's less of a risk, but if sensitive populations like children, babies, or pregnant people are present or may be present in the future, or if there's a lot of use in general, consider using a contractor. Next, while we have cleaning steps for porous materials and HVAC in our guidance, we aren't confident that they'll always work. So hiring a contractor is better because they have more training and they can provide informed recommendations on whether to replace porous materials and also how to get your HVAC system properly decontaminated. And finally, contractors will have training on addressing other hazards like mold, asbestos, and lead that may become disturbed by heavy cleaning or renovation. So the next section in our guidance is called assessment. In situations when decontamination by a certified contractor is not required, how do you decide when and how to test? So assess an area for drug residue. The Department of Health does not have a policy that specifies when to test for methamphetamine or other drug residue from use. We recommend the property owner works with their local health jurisdiction who can help them decide when to test. There are several factors that should be considered when deciding whether to test. So as I mentioned on the last slide, high levels of drug residue aren't always visible. So a lack of visible drugs doesn't mean you don't need to test. The images on the right are of a composite sample taken from a residence in Colorado. So sorry, the pictures are pretty small, but these pictures show no visible drug residue where they sampled. So you can see where they sampled in the squares that are on the surfaces. The methamphetamine level that was detected from the sample is over 400 micrograms per 100 centimeters square, which is very high above the state decontamination standard of 1.5, demonstrating that there can be a health risk from drug residue that is not visible. And in this property, the contractors who were doing the testing found paraphernalia in this house indicative of use and no evidence of manufacture. So heavy use can produce very high levels of residue. So similar to considerations for if you're hiring a contractor, consider testing if heavy use is known to have occurred. Also, if children or pregnant people live in or use the area, consider testing. And finally, testing in between long-term tenants or residents of a property can be a best practice because it'll be much easier to clean the area if no one is living in it or using it. For how to test, we consider hiring a contractor in consultation with local health to be the best practice for testing. We also don't generally recommend using field tests for multiple reasons. For example, test strips tell you if a drug is there, but not necessarily how much, and they also won't necessarily test for all drugs. Overall, we're hoping that by following our cleaning guidance and other exposure reduction practices, that the regular cleaning will remove the drug residue and so reduce the need for testing and potential expensive decontamination via contractors. So here are some additional images of another composite sample that revealed high levels of methamphetamine residue. This was in a typical hotel in downtown Denver, Colorado, at which you would spend a regular hotel stay, so not an extended stay. The composite sample was on, as you can see, 2 walls, a table, and a ceiling, and revealed about 378 micrograms per 100 centimeters squared of meth. And according to the contractors, there was no evidence of meth manufacturing, but they did observe paraphernalia typically associated with illicit drug use. So our next section of the guidance is on selecting a cleaning or neutralizing solution. So how do you choose a cleaning product? There are 2 types to choose from. Neutralizing solutions degrade the drugs, meaning the active drug will not be present anymore. These products require training to use because they can be multi-part and so need to be mixed. They also may carry their own hazards and so have PPE, personal protective equipment requirements, such as having an eye wash on hand for some of them. And they are less easy to acquire in some cases and more expensive. An example of an effective neutralizing solution that works on both meth and fentanyl are products with peracetic acid in them. General cleaners that you can find at the store won't break down the drugs. They will just help move them from the surfaces into the wastewater. So some facilities or properties may not have enough resources to use neutralizing solutions, and so will need to rely on more general cleaners. One example is that you may have heard of is Simple Green. This one is commonly used to clean up methamphetamine. Bleach has also been shown to be effective at degrading these drugs, so as a neutralizing solution, but we don't recommend necessarily using bleach due to the risks of bleach mixing with other chemicals that may be present, because this can potentially lead to the formation of dangerous chloramine or chlorine gases. So mixing bleach with other cleaners can happen unintentionally when people are using multiple cleaners on the same surface. We coordinated with labor and industries for the hazard communication aspects of this section. If the people doing the cleaning are workers, they fall under L&I jurisdiction. If they aren't employed, we still recommend following L&I's recommendations for workers as best practice. And we've compiled all of the technical info that we've gathered from the literature on products into a separate document, which is also available on our drug residue website. And here are some screenshots of that document. It's called Technical Information on Cleaning Products for Fentanyl and Methamphetamine. In this document, we have information on general cleaners, hydrogen peroxide-based cleaners, peracetic acid cleaners, bleach products, miscellaneous active ingredients that are tested in laboratory settings, products marketed to law enforcement, and then non-chemical cleaning agents such as UV light and ozone. And we have one column for effectiveness against fentanyl and one column for effectiveness against methamphetamine. So this is just if you really want to get into the technical information and aspects. And then also look into the effectiveness of different cleaners depending on different surface types as well. So the next section of the guidance begins with information on personal protective equipment. There's a data gap in the literature on PPE recommendations for drug residue resulting from use. So we worked with L&I as well as our DOH industrial hygienist to create the PPE recommendations. Our minimum PPE recommendations are to wear gloves and an N95 respirator. These recommendations should be superseded by product label PPE requirements if they are more protective. So next are the steps for residue reduction. Step 1, we highly recommend turning off the HVAC if possible. This is the first step because it's the highest priority, because the HVAC systems often have high levels of drug residue inside their components. and need to be cleaned, and also risk respreading the residue to the area once you've already cleaned it, once you turn the HVAC back on. So if there are large amounts of fentanyl powder present in the area, we are also worried about the air circulation from the HVAC and kicking up the particles and causing an inhalation hazard. So we say turn off the HVAC if possible, because it can also cause unintended consequences by turning it off, such as building pressure changes, as well as reduced air quality in the other areas that are not affected by drug residue. The second step is to pre-wet the area in order to prevent spreading the residue to non-affected areas and also prevent it from becoming an inhalation hazard while cleaning. We advise you to keep the area wet while doing the following cleaning steps. You may also be familiar with this sort of pre-wetting step if you've ever cleaned an area or ever had professional contractors clean an area of other inhalation hazards like lead and asbestos. Step 3 is pretty self-explanatory. If you can clean materials outside, then take them outside to be cleaned. Step 4 is to clean the textiles, so the fabrics in the area. According to the literature, you only need to run your fabrics for 1 cycle with detergent in a washing machine to get the drug residue out. If you're worried about your machine containing residue afterwards, you can run the washing machine again with detergent without clothes to clean it. For fabrics that you can't fit in the washing machine, we recommend pressure washing followed by wet vacuuming. If you don't have a pressure washer or wet vacuum, we recommend scrubbing the material with hot water and the cleaning solution. This is based on a cleaning protocol that Community Transit, the public transit authority, shared with us that they use to clean their own buses. They showed that this method was able to reduce meth in their seat fabric to below the decontamination standard, as well as fentanyl to well below the ACGIH surface limit standard. For step 5, cleaning top to bottom prevents re-spreading the residue by keeping track of where you've cleaned and preventing drips, etc., to re-spread residue to lower areas that were already cleaned. And step 6 is for cleaning porous materials, which are materials that have tiny pores in which drug residue can become trapped. So, for example, wood or granite. Porous materials are very difficult to effectively clean. So, decontamination by contractors will actually require removal and replacement of porous materials. However, we understand that removing porous materials is expensive, and so we've done our best to provide guidance on the best way to clean these surfaces based on what we found in the literature. We cannot promise our recommended cleaning steps will remove residue to safe levels, so below the decontamination standard, because it hasn't been tested yet, but we are looking into ways to test our guidance. Neutralizing solutions will be more effective since they degrade the drug on the surface. And we recommend also using a wet vacuum to dry the material to prevent mold growth. Overall, when in doubt, if a material is porous versus non-porous, assume it's porous and treat it that way. For step 7, cleaning non-porous surfaces, so like glass, for example, is much easier. You can do this by spraying them down with the cleaning solution and wiping off once. Of course, if there is a visible mess, then that will require more cleaning. For step 8, as I mentioned previously, don't let surfaces dry before wipe cleaning them up. Otherwise, the active drug will dry on the surface, and studies show that it will be much harder to clean from the surface. This step runs concurrently with the steps for cleaning surfaces. And we also still recommend this step even if you're using a neutralizing solution, because even these solutions won't necessarily degrade 100% of the drug. Step 9, HEPA vacuum, if you're able to. This cleans residual particles that are left on surfaces, and this is especially helpful for porous materials like carpet. So step 10, dispose of cleaning materials responsibly. Local regulations for disposal will vary. Household waste and waste from small quantity generators are considered moderate risk waste, and that is managed at the county level. We have more information in the actual guidance on disposal, but it's very specific to the county, the facilities risk designation, the waste risk designation, and then the size of waste generator of the facility. And professional contractors will make this process easier by handling it for you. Lastly, we recommend conducting follow-up testing. This guidance is the first of its kind. So as I mentioned earlier, we don't know how effective it is. But even contractors often have to repeat their decontamination process to get drug levels below the standards. So retesting will tell you what areas need to be cleaned again. We have a section on preventative practices that a property can do. Renovation to remove porous surfaces is an option, and it doesn't have to happen immediately. These are recommendations to use when the time is right for your building or property or facility. If you do choose to renovate, we have information in the guidance on other hazards that may be present, like lead, asbestos, mold, and rodents. And overall, we recommend you continue to keep the area clean as an act of prevention. So while levels of drug residue can be above safe levels when not visible, a visibly dirty area may have more hazards from drug residue and paraphernalia as well. Elevated drug levels have been found to correlate with visible surface dust accumulation. So that's it for our main guidance. This slide shows the other resources that we've created or contributed to that are available on our drug residue webpage, and I will show some examples of these on the next slides. We have guidance for vehicles. So in 2024, House Bill 2396 directed Department of Health in consultation with Washington Poison Center to compile resources on how to decontaminate vehicles of fentanyl residue. So to fulfill this request, we adapted our guidance to vehicles and included information that we gathered from the Department of Licensing, other state health departments, as well as other sources. We also created a separate background information document that includes additional information that was too technical for the main document. And both of these are available on our drug residue webpage. So we, alongside the clandestine drug lab program at Department of Health, also worked with LNI to create 2 partner documents specific to fentanyl in the workplace. These include information on hazards, what employers and employees should do, as well as LNI requirements and resources. These documents are also available in Spanish, Russian, and Vietnamese as well. And while not directly linked on our drug residue webpage, I also wanted to highlight some recently published documents available on, there's the Fentanyl Exposure in Public Places webpage. We provided input on these documents during a work group that was formed to fulfill the requirements of Senate Substitute Bill 6109, which directed Department of Health to develop guidance to help Washington courts consider how high-potency synthetic opioids, so fentanyl, impact child safety, because there have been increased reports of children accidentally ingesting and overdosing due to fentanyl in the home. There is the main technical document, as well as 3 other shorter documents available. And these 3 shorter documents are focused on facts about fentanyl, an explanation of how risks change according to developmental stage and age, and finally, a fact sheet about medications for opioid use disorder. As part of our work fulfilling 6109, we've also been working on adapting our guidance to child welfare workers as well as parents. So these guidance documents are still in draft form and aren't publicly available yet, but we're hoping to publish them in the next few months, so stay tuned. So that's it for our slides. Thank you so much for inviting us to speak today. Let us know if you have any questions or feedback, and our contact information is here, so feel free to reach out to us after today as well.
Thank you so much. If folks have questions, please pop them into the chat. I can probably come up with 1 or 2 while we wait, and we'll give you a second to formulate your questions. And again, just put them in the chat on Whova or Zoom, and I'll certainly keep an eye out for those. So I had a quick question. You talked about the HEPA vacuum, right? What's the difference between a HEPA vacuum and, say, the Dyson that I use out in my living room?
Well, for one, I believe that Dysons are equipped with HEPA filters. But HEPA vacuums are equipped with, I believe it stands for high efficiency particulate air filters. And so we advocate for using vacuums that are equipped with HEPA filters because those will effectively filter out the particles that are being sucked into the vacuum while you're vacuuming. And so then they won't then be kicked out into the exhaust. Whereas a normal vacuum will not necessarily have this sort of filter, and so will then kick out those particles and then potentially re-expose the area with the drug particles.
And
Sure.
we haven't, this is great, we haven't had this question before. And you mentioned the Dyson. So I would also say we wouldn't recommend using a bagless vacuum, because then with the step of pouring out all the stuff that's in there into a bag, you again could have the particulates in the air that you could accidentally inhale. So we
Cool.
should
And I
add
think
bags.
I appreciate that. I think you address this, but I really want to tease it out because I think it's really important. There still hasn't been any confirmed cases of overdose from secondhand smoke or from solely touching fentanyl, correct?
But not for secondhand smoke, for touching fentanyl only in the case of children who there was, for example, a case of a child who was asleep with their caregiver and accidentally got a transdermal patch attached to them and unfortunately overdosed. But not in adults. And it's very rare in general that overdose occurs from dermal exposure.
Mm. And I thought it's interesting, I just want to tease this out a little bit. You mentioned, or your slide mentioned that the real risk with the exposure with touching is if you get it on your fingers or fingernails perhaps, and then it comes in contact with the mucous membrane, right?
Yeah, so that's part of why we advocate for wearing gloves, because then that's a physical reminder. It's not necessarily to stop the fentanyl or other drug residue absorption through the skin, because we're not really concerned about that. It's more of like a reminder to not touch your eyes or eat something while you're doing the cleaning.
Yeah, I remember when COVID started and we had to start wearing masks all the time, and it was shocking to me how often I, would not consciously be aware of like touching my face or touching my nose, mouth, etc. So I think that's a really valuable point to share with people. Thank you so much. It doesn't look like we're having any questions in the chat, so I just want to again extend our gratitude for hosting this in our overdose series. I think it's, as a trainer myself with naloxone, opioids, and stigma, it's a question I get a lot of, and there's a lot of fear around it, I think. And so dispelling some of the myths and talking about realistic concerns also, I think is really valuable to share. And we just really do appreciate your time very much. So thank you.
Yeah, and I'll just mention that one of the 6109 documents is dedicated to facts about fentanyl, so kind of myth busting, and also addresses that dermal absorption piece. So we invite everyone here to look at it to learn more.
Wonderful. Thank you both so much. And everybody, will see you at our next session.
Thank you.
Thank you.